All right, good morning. Let me put my slides here and we will get going. Welcome to Project Echo. This is our third training in our current series of 4. As a reminder, we do these trainings in cycles of 4. Today we have Stephanie giving a talk on ADHD and substance use disorders. Do my quick usual housekeeping slides and then I'll turn it over to our experts. Let a few people in the waiting room here. Usual disclosure of relationships. No one that's involved in this project had any financial relationships to disclose. And our funding statement, we're grant funded. Our funding comes from the State Opioid Response grant from SAMHSA by way of Nebraska Department of Health and Human Services. And then the usual process for CME certificates. At the end of the training, you'll get an email with a link. Do this quick survey and your certificate will pop up automatically. I'll also drop in a link to that survey in the chat at the end of the training today. With that, I'm going to turn it over to our experts to introduce themselves. Janet, you want to introduce yourself first?
Yeah. Hey, I'm Janet Bernard. I live in North Platte, retired family practice doctor, started using Suboxone in 2008 until about 22. So.
Ed?
Yeah, my name is Ed Kaiser. I'm a nurse practitioner here in Omaha, Nebraska. Little background in like ER urgent care, but have been working with substance use disorder, primarily Suboxone, for about the last 5 years. So.
Thank you.
I'm Gail Keller. I'm from down in Falls City, Nebraska. I have been working with Suboxone for a few years, but it's just been a nice addition to our community. So I hope that everybody else will do it as well.
I don't see Todd Stoll or John Massey on, so Stephanie, I will turn it over to you.
Sounds good, thank you. Let's see if I can pull this up. Okay, can everybody see the screen okay? Just want to make sure that actually shared right. Perfect. So today's topic will be about substance use disorder and the considerations in the treatment of ADHD. So as Will already mentioned, there's no outside support for this activity, and I have nothing to disclose regarding financial interests. Today's learning objectives we'll kind of discuss some of the basics of ADHD. So first, we'll kind of discuss the benefits of ADHD treatment in adults. We'll kind of review the relationship between substance use disorders and ADHD, identify treatment strategies for substance use disorder and ADHD, and then learn about the characteristics and methods to reduce prescription stimulant misuse. So first, kind of looking at ADHD itself, the prevalence is actually fairly high. When we look at children and adolescents, we see that it's between 6 and 9%, and we see in later adolescence to adults, it's 4 to 5%. And so this was a common misconception in kind of the earlier days where we thought this was a diagnosis of childhood, and really we didn't have any other studies to support that it wasn't. And so more recently, in the past 10 years, we've now come to learn that this is a diagnosis that has a chronic course. And we actually see 50% of the children that are diagnosed in child and adolescence do continue to have symptoms into adulthood. It's not that they don't, just because they still do, but some adults can develop coping mechanisms if they have more mild symptoms and are able to manage, their symptoms through other means. But 50% of adults do continue to have persistence of significant symptoms and would require medication. There's high rates of psychiatric comorbidity, which we'll discuss later. And there's impairment in multiple domains for these individuals, which causes significant impacts on individuals' lives that have ADHD. With the new DSM-5 criteria, I shouldn't say new, I mean, we've had this for a while, but the major changes that they made was they put it into the 3 subgroups, the combined, inattentive, and hyperactive subtype. The combined is the predominant, about 60%, and more so in adults, we see more of a combined, and it's not atypical for children to present with one subtype or the other, and as they go through adolescence to adulthood, they mold kind of into this more combined type. One really interesting thing about ADHD is we have great medication for it. It responds really well to treatment, which I'll discuss here in just a little bit. ADHD is not as obvious as some of our other diagnoses in mental health and across medicine itself. There's no blood work or brain imaging that can be used to formally make the diagnosis. It is a diagnosis it's a clinical diagnosis. Physicians and providers will commonly refer patients for neuropsych testing, but this we have found is not consistently reliable, and it's not required to make the diagnosis. And so, I've seen psychiatrists where they may not have the preference of wanting to treat ADHD, will refer for neuropsych testing on the basis of if they actually go and perform the testing, then that means maybe they truly have ADHD, and not performing it means that they maybe don't. And that's not a valid treatment. As we all know, neuropsych testing is extremely expensive, and a lot of individuals will have to pay a significant portion out of pocket. So just kind of keep that in mind if when considering referring for neuropsych testing. So let's kind of I'll kind of touch just briefly on this because it really kind of leads into everything else that we're going to talk about today. But looking at the evidence-based treatments for ADHD, we have stimulants, of course, and then non-stimulants. But one thing to keep in mind, stimulants are the first-line treatment. They're not the last resort. And from the past 10 to 15 years, we've kind of been in this mindset that when treating ADHD, we go to non-stimulants first for safety concerns within the provider themselves. But research has consistently shown that stimulants are first line and not last resort. We find that they're more effective than non-stimulants, and but at the same time, at the offset, they could be likely to be diverted, abused, or misused, and we'll discuss a little bit more on the research of that as well. They typically have mild side effects, and with a significant reduction in the consequences seen in untreated ADHD. The non-pharmacological treatments that we have are significantly less effective than stimulants, but they could still be useful in certain patients. And I put at the bottom, we currently only have one scale that can actually monitor the progress in medication response trials, and that's the Connor Global Index Scale. But this was designed to be used for children ages 3 to 17. So in adults, we don't have a reliable scale to determine the response to treatment. So this is probably one of the biggest studies that we did, kind of looking at the effect of stimulants. And I find this quite amazing. And I don't think a lot of people truly understand how well stimulants work. When we look at the effect size, we see that in the studies, when they would use a forced dose, meaning they would arbitrarily pick a dose for stimulants, it had a really good effect size. I mean, it was great, 0.95. And that was kind of just arbitrarily picking a dose. When in the studies that fine-tune or they dose optimized, and this is including to doses well beyond FDA-approved guidelines, the response was truly amazing. Actually in medicine, we don't have any other response as seen in that with stimulants and ADHD. We don't really have the ability to treat any other disease like this as we do with stimulants. And if you even look at some of the other, some of the other disorders that we have in mental health, kind of comparing the two. I mean, when we look at major depressive disorder, it's significantly different when we compare it to stimulants. For the actual treatment of that disorder, we have a 0.5 effect size, and SSRIs for anxiety disorders is even less. But the truth is, both SSRIs work really well for major depressive disorder and anxiety disorder. Those are good scores when we're actually treating condition. They just don't look as good comparative to the response that we've seen for stimulants with ADHD. So that just puts kind of in a straightforward way of how well these medications work for ADHD and why it's considered first line and not last resort. So why should we treat ADHD? What's the major concern when we're looking at patients that have untreated ADHD? Multiple reasons, right? Which we all are well aware of. When we screen for it, looking at some of the symptoms back in childhood versus what if we have an adult, these are consistently the questions that we ask. And we'll frequently see that they'll repeat a grade, maybe drop out of high school or not have as good grades. Teen pregnancy is an issue. STDs, substance use, which we'll get into more obviously with this lecture, but as we can see with the scores, accident-prone substance use are significantly high. Serious car accidents, of course, from that impulsivity, not paying attention, distractions, more likely to be arrested, incarcerated, and fired from a job, which we commonly will see with the adult population. So when we look at substance use and ADHD, there is a strong overlap between the two. And this has kind of been the focus of a lot of the research in the past 10 years of really looking at why and what are we doing and what we could be doing better. And as we see with ADHD and substance, there's a strong overlap. We also find that there's a more complicated course of substance use disorder with ADHD. Untreated ADHD leads to more severe substance use disorder. There's higher rates of other psychiatric comorbidities, such as conduct and antisocial disorders. There's less remission from substance use disorders when we have untreated ADHD. There's a longer course of substance use disorder, and there's lower retention in nicotine and substance use disorder treatment. So these are the individuals that will frequently start substance use disorder treatment, but will frequently drop out early, but will continue these are the frequent triers. They'll try and try. They truly have the motivation to do it, but without that treatment of the ADHD, it's extremely difficult for them. And these, just kind of a slide, just as a reminder, some of the major brain circuits involved in addiction, which are overlap with those seen with ADHD. I mean, we look at the reward dopamine pathway, and of course the prefrontal cortex and our attention and inhibitory responses. So as we know, substance use disorder is a risk factor for ADHD. There's prior to 10 years ago, there wasn't substantial research that really looked at the differences in substances and treatments. So in the last, probably more so 5 years, there's been major advances in research regarding this. But prior to, I think this was in 2012, they really looked at the differences in the substance uses with ADHD. And in 2 of the studies, they found that it was polysubstance, opioids were 3 studies, cocaine 3 studies, and alcohol were in 3 studies. So, and they found that the alcohol had a significant comorbidity with untreated ADHD. This kind of looks back at the studies that when it first started examining ADHD with substance use disorder. And originally it was thought that stimulants would be the primary drug of choice for untreated ADHD. And as you can see kind of in the research, it's not a predominance of just the stimulants that are preferred by untreated ADHD. They have a predominance of just substance use disorder in general. And because some of the newer studies are consistent with what's shown from the prior studies, and it's about a 20% prevalence rate of the substance use disorder with untreated ADHD. And again, this kind of looks at some different pathways. Nothing is ever truly known in psychiatry. It's all kind of trial and error. but this is different pathways that could be setting potential pathways that kind of lead to the increased risk of substance use disorder. If it's upbringing, if it's genetics, and from the research, it's kind of all of the above we see. So the first question we have to ask is, does treatment of ADHD in childhood impact later substance use disorder? Is this something that we need to be targeting in treating these kids earlier in life, to prevent the potential risks of substance use disorder later in life? And the newer research says yes, it does. By treating it earlier, we do see a decreased risk in certain substances. One of the biggest studies that we have with the biggest cohort of patients that were involved in this study was from 2017. And as you can see in the number that were studied, from 15 to 42 years, there was a significant reduction in later substance use with treated ADHD. Early ADHD treatment reduces cannabis use. In a study, I think this was completed in between 2005 and 2014, they found that stimulant use started prior to 9 years of age reduced the risk reduce the use over the past year of cannabis. And there was more of a statistic result between 10 to 14 years, and stimulant use started after age 15. So irregardless of when the treatment started, it will have an impact on decreased use. And so, but the data shows that prior to age 9, kind of when those symptoms really become an issue, can have the most benefit to these kids. One of the major concerns, which even in my residency, I've heard across even today, was that early onset ADHD treatment can potentially increase the risk for cocaine use or maybe methamphetamine use. And the research shows that that's not the case. It's actually the opposite. If we treat these kids, if we treat their symptoms, we have less impulsivity, less desire to almost self-medicate, then these kids have a better outcome. We have also looked at nicotine, and the results are similar, that childhood ADHD is related to future nicotine and substance use disorder. And this kind of just puts it into kind of graph form so you can actually see the impact. And same thing is true for vaping, which is something we're seeing, more commonly today. We see high rates of nicotine use in vaping and ADHD versus non-ADHD. We have high rates of ADHD in e-cigarette use. Nicotine may be experienced differently in ADHD versus the controls. Specifically, it's more pleasurable experiences, the research shows. There's really no difference in the unpleasant experiences. And there's a similar response to other predisposed substances such as alcohol. So nicotine is a major concern for these kids. And the previous work has shown nicotine enhanced cognitive functioning in ADHD. So it's almost like a self-treatment that these kids end up trying it. It makes them feel good. It makes them more motivated or more focused, less impulsive or less angry. And then they just kind of just self-treat with it before it kind of spirals out of control. But one of the major advances with this study is we see that when you have kids in your office, for those that see kids, if nicotine is a primary issue and having a lot of difficulty coming off nicotine or e-cigarettes, keep in the back of your mind that potentially this is a kid who actually is struggling with ADHD, and this could be the presenting symptom of that. And so the next question we have to ask is, treatment of ADHD in naturalistic settings improve outcomes? And this was a recent study that was published last year that really looked at stimulants for ADHD. And it's really the first time we've actually had a study where it compared ADHD medications with other medications to see the impact it had on hospitalization and mortality. And so the study went for, I believe it was 16 years, if I remember correctly, but the median follow-up time for most was about 4 years, which is a significant amount of time given the number of patients that they had. And as you can kind of see below, About 74% were hospitalized due to substance use, and then 82 of the cohort were hospitalized due to any cause, and about almost 10% died of any cause. And this is with individuals that were hospitalized with an amphetamine use disorder. And so what we found with this trial was pretty remarkable. Like I said, we didn't really have any studies that really looked at the stimulants for ADHD. And so this was kind of really the first trial that really promoted that we need to be treating this like any other disease. And so if you kind of look at the results and looking at the significance of, p-value, we look at the combination ADHD medication and then of course Vyvanse right underneath it. And combination ADHD medication is something we will commonly see across providers where maybe they'll be giving Vyvanse and then maybe the patient will struggle in the evening and they'll kind of add on a different medication in hopes that will resolve symptoms. And while it resolves symptoms in this study, they did not find it decrease hospitalization. It seemed to have almost, but it wasn't a significant value. The only major significant values in this study was for Vyvanse. And it was quite significant that it decreased the risk across hospitalization, mortality, and all cause of death when ADHD was treated by Vyvanse. The other significant value that you'll see is combination substance use medication. And this was specifically with opioid use medications with ADHD medications being treated for the ADHD. So they had opioid use disorder, and then they also had the ADHD treatment. And when that ADHD was treated with Vyvanse, with whatever opioid use disorder medication that they use, there was a significant reduction in hospitalizations of these individuals. And just I highlighted the two at the bottom, that antidepressants and benzodiazepines actually increase the risk of hospitalizations for individuals with substance use disorder, and then they were treated with an antidepressant or a benzodiazepine for whatever illness. So this is looking at the cause of death. Again, we see that Vyvanse is significant, and the combination of Vyvanse with a substance use disorder medication, specifically for opioid use disorder, we found a reduction in hospitalizations due to any cause or death. And then when we look at just all-cause mortality, we see that both Vyvanse and Ritalin had a significant reduction in all-cause mortality when those individuals were actually treated and had substance use disorder. And if we see, again, I just wanted to point out for benzodiazepines, it actually increased the risk of all-cause mortality. So that's just kind of something we all know it, but it's kind of nice to actually see the data associated with that. So some common assumptions that I'll lead into as we go through this discussion is I'll kind of go into the common assumptions that we have today when we're considering treating individuals for ADHD. The standard treatments for ADHD do not work in active substance users. That's a common misconception. Even if treatments work for ADHD, they do not impact on the substance use disorder. Active substance users will misuse and divert their medications. Often there are numerous psychiatric comorbidities, make it even harder to effectively treat these individuals with ADHD and substance use disorders. So these are commonly things that we all, or even we ourselves even maybe have thought as we have these patients come into the office. And so in order to fully explain the data associated with this, I want to get into just briefly discussing the mainstay of medications that we have for extended relief medications and the decreased risk of a lot of those misconceptions. So we have methylphenidate ER, which is our Concerta, and then we have the Vyvanse. And these are probably our two biggest breakthroughs in ADHD medication. And we'll get into this more as we go on. But they have the decreased risk of misuse. Not saying it can't be done; it certainly can, but it's more of a barrier we have with the immediate release medications. So for our Concerta, it works quite a bit differently than really all of our medications that we have in medicine, but it uses this osmotic delivery type system where it has these little permeable membranes, and once it goes into the GI tract, then the osmotic pressure will control the release of the medication into the system. And then with Vyvanse, we have the prodrug that requires first pass metabolism in order to become activated. And it's how I describe it to patients. It's a cleaner version of Adderall, where it becomes the active component of Adderall, but it's taken the major component of it, and that causes the greatest reduction in symptoms with the least amount of side effects. What we also are seeing currently in clinical practice, and the research supports it, is we are needing higher doses of medications to be truly helpful for ADHD and cocaine use disorder and opioid use disorder. And this is a pretty important study that was done to kind of look at this, because when the original medication studies were completed, and they, as I mentioned before, where they had the forced dose versus they had the titrated dose. When they did the forced dose medication, they kind of arbitrarily chose these max doses. There's really no research to support that these should be the max doses. It's just that's what they studied at the time. So that's what the FDA approved. Now, we don't have enough data to say that higher doses would be more effective, that the FDA will approve. However, studies more recently have been done that have shown if we maximize on the dose, we will further decrease the use of the substance use, specifically with cocaine use and with opioid use. So this is something to definitely keep in mind for these type of patients that come in, because under treating could cause more risks later on for these individuals. And so we kind of have to look at the benefit versus risk, and by maximizing on that dose, potentially to levels that the FDA has not approved, are sometimes what is needed for these individuals. And I just wanted to make a side note for the opioid use disorder and stimulant medication. This is a relatively new study, actually, just released last year. And one of the major studies actually looking at opioid use disorder and stimulant medication. And what was found was that when you have stimulants being used as a treatment for ADHD with buprenorphine, there was a modest increase in the risk of overdose and drug poisoning, but this risk is offset by improved retention in buprenorphine treatment. And so you kind of really got to weigh the risks and benefits when it comes to this. In this study, the dose was not maximized to the level that we have seen in previous studies, so that could be a limitation of the study. But the major concern to kind of have in mind is having this conversation with patients and having the frequent follow-up. Really, you want them to retain treatment in buprenorphine and opioid use disorder maintenance medications in general, because we have found consistently, because that will lead to the greatest reduction in the substance use and maintenance periods. And so that's the ultimate goal. And the study kind of supports the fact that if we truly do treat ADHD and the opioid use disorder, these patients have improved retention. And then they did examine the safety of buprenorphine and stimulants, and it was found to be considered safe for the combination of the treatment, other than what was mentioned above. Some other more recent studies that kind of looked at the efficacy of the clinical practice of ADHD medications. And one of the major populations we have found to be where it's beneficial is with ADHD criminal offenders and amphetamine use disorder. And it's actually, the results are all positive. We found that the greater improvement in ADHD symptoms for those on methylphenidate and it reduced their ADHD symptoms by at least 30%. So that's pretty significant, because when we're dealing with individuals that have already been in the criminal system, the risk is already higher. We want to make sure that when they actually get out of incarceration, that these patients are set up to succeed. And one of those is actively screening for the ADHD and effectively treating it, potentially at doses that are past FDA guidelines. And just to kind of put it in perspective, how they use self-report on whether or not that they continue to use amphetamines post-incarceration, and then they would verify it by urine testing, and they found that with the stimulant group, there was a reduction. So one of the probably the significant research we have is with ADHD and cocaine use disorder, and this is again, the research kind of supports potentially having to increase those doses in order to get the effective response. But the newer research really supports treating the ADHD symptoms with a stimulant does effectively reduce the symptoms and relapse with cocaine use disorder. And this looks at the different, for this particular study, they examined 60, 80 milligrams and then the placebo. So you can see that there was 30% achieving abstinence lasting 3 weeks in the maintenance phase, which is pretty significant for these individuals. And again, this is looking at the three, kind of putting into a different graph. But one of the concerns was how the missing data was interpreted. And so this particular study interpreted it in two ways. So they interpreted the missing data as just missing, so it wasn't included in the results. And then they interpreted the missing data as actively using again. And they found that however they interpret it didn't statistically change the results of the study. As you can see with the graph, it was still significant, irregardless of how they interpreted the missing data. So just kind of going through all the different substances, just so you guys are aware, even with cannabis and co-occurring ADHD and cocaine use disorder, even having that polysubstance, that having the mixed amphetamine salts, extended release, found a reduction in the substance use. So cannabis users were defined as use in the 30 days before study initiation, and the data was collected with timeline follow back. And so as you can see, that as the study week continued on, that the maintenance period was statistically significant comparative to the placebo. So another assumption that still is prevalent today is active substance users will misuse, abuse, divert their medications. And where this assumption really came to light was it's a certain population. So when we think about this, we first have to ask, what do we know about stimulant misuse, non-medical use of stimulants? When you think about it, what comes to mind? And really where we got this information is a population of predominantly age 21. So we're looking at this college age. And as you can see in this graph, it kind of goes up about 21, kind of peaks, and then we gradually start reducing that misuse. And so when we look at the studies, which about 120 studies that were looking exactly at this, it mostly surveyed studies in college students, about 80%. There is a 10 to 20% prevalence of non-medical use of stimulants. 65 to 85% of these stimulants that were diverted were actually coming from friends. They were not coming from quote unquote scamming local doctors or doctor shopping or getting multiple prescriptions when they shouldn't. So it was actually getting from friends in this college setting. So this was not seen as potentially dangerous. And some reasons why they were misusing stimulants was concentration focus, staying awake, reduced distractions, energy, just to experiment, have a good time with friends, to feel good or get high, and to get through the day. And as you can see, to feel good or get high was lower compared to concentrate or focus. So in this proportion of students that responded to this, the odds are a lot of these students probably could meet criteria for a diagnosis of ADHD had they actually gone the proper steps to actually try to get a valid prescription. So just kind of put it in graph form, rates of ADHD are higher in college students who misuse stimulants compared to controls. And so it's this self-treatment that they're kind of dabbling in. And they know people that have the medication. They've long thought maybe I have symptoms, but there's the fear of stigma of actually getting that diagnosis, and so they'll get it from friends. And so, but in honesty, that if they actually went, like I said, if they actually went to have a formal assessment, the odds are that they would likely be diagnosed with ADHD and would probably have symptoms, dating back into early childhood. The immediate release stimulants are misused by college students more with a stimulant use disorder. So, as we know this, Adderall is immediate release. Adderall is the preferred misuse substance, and then it kind of goes down from there. And that is due to the likability of the immediate release. So, as the person orally takes that medication, they are going to get the most significant dopamine transporter binding, leading to the euphoria and the likability within that first 30 minutes to 60 minutes. Where they looked at the study, they also looked at the methods that these college students were actually taking the medications, and surprisingly, they were actually swallowing them. So it's a common misconception that patients will, the most common use of misuse is maybe injection or snorting, and snorting is high up there, but the predominant method of using these medications was actually orally. And I found this graph actually kind of interesting, so I included it in here. There's this overwhelming fear that ADHD medications will be the ones that will be misused. When you look at this graph in this college population, it's actually not the most common ones that are being misused. It's, the analgesics, and even asthma medication, because it has, some of them has the stimulant properties, and then other psychotropics. So ADHD medications are more likely to be misused for the ones that are actually prescribed. And that goes back to the fact that it's coming from friends. So that makes sense. But yeah, it is not the most common misused prescription medication in the college population. So when we look at adults in misuse, we actually kind of see a shift from Adderall over to the Ritalin group, which is interesting. So we have the Adderall IR, which is still higher than the respondents for the other medications, but Ritalin is still the most commonly misused in the adult population. And it goes back to, of course, being the immediate release. And then Vyvanse, XR, and then Concerta being the least common. So when we look at kind of all of this data and the research, what does that really tell us about the misuse? Should we be fearful of it? And the clinical experience that we have found with it is the consensus of many of these trials show that maybe it's not as big of a concern as we once thought. There are certain comorbid conditions that increase the likelihood of misuse, most notable being bipolar disorder. But none of the clinical trials where they're actually looking at this actually reported diversion or misuse to be a major concern. The study evaluated misuse and subjective effects of both Concerta in 2 different trials, both adolescents with substance use disorder and adults with nicotine use disorder. And the adolescents with substance use disorders were not more likely than adults with nicotine use disorder to describe this feeling of euphoria. So it was similar across age populations. They found that the adults were more likely to lose the pills. They need the replacement pills than adults, but among the adolescents, no difference between those taking the methylphenidate or the placebo. So some considerations before starting or once start stimulant medication. Of course, carry out a structured interview and assess baseline level of functioning. For adults, really, we just have that adult ADHD diagnostic scale, which, as we all, if you've ever administered that, some patients may be more likely to report symptoms, knowing for well it is what that assessment is for. You can discuss goals of treatment and how improvement will be determined. And really, that's one of the most important aspects when starting or during stimulant medication for ADHD. Overall, you want the improvement in functioning. It's not simply the reduction in their ADHD symptoms or what they think are the ADHD symptoms. It's that overall improvement in functioning. Are they actually getting to the appointment on time? Are they remembering the appointment? Are they getting maybe some promotions at work, or people noticing their work function? Is their spouse saying, making positive comments about interaction with kids? Maybe they're not as moody. Those are important things. So it really is important to bring in the collateral information, family members into the treatment to kind of really assess if it's working. And that comes to getting examples of that improvement and really documenting those examples. That's the important aspect, because if you do have to go past FDA approved guidelines for the dose, you really need to document what improvements or lack of improvement to be able to justify that. You need to use an adequate dose, as I said, including higher than the standard dosing, and you got to have that ongoing assessment of clear functional improvement, reviewing the benefits and the risks. And one additional major concern with this is patients will be started on a stimulant, and then if it mildly works, then a lot of providers will just stop there. And now we're kind of setting them up for potential significant risk, especially with substance use, if it's already co-occurring, because undertreatment can substantially increase that risk of substance use disorder or relapse because of that undertreatment. So it's not just looking for just initial improvement. We want them to have overall improvement in functioning. So just briefly, just kind of mention cardiovascular effects. This, has long been concerned about the major effect or side effect that we are fearful of, where we get EKGs, making sure that there's not comorbid cardiac or undiagnosed cardiac dysfunction, which of course these things still need to be in practice, and then continue to monitor blood pressure and heart rate at baseline and with follow-ups. And when a patient is not responding to the medication or having side effects, it's really that diastolic number that's going to increase that you really need to be monitoring for on follow-ups. And then if we generally see systolic, if it's a co-occurring substance use and potentially ongoing use when we have the ADHD stimulant use with the substance use disorders. Another side effect, increased agitation and anxiety, consider an alternative medication, and of course, increased mood lability, which the mood lability should gradually decrease as the medications continue to work. And I wanted to just briefly mention this. This is was released last year. Significant study put out that looked at actually the risk of cardiovascular diseases, and they actually found there was no significant risk associated with stimulant use disorder, cardiac arrest, arrhythmias, cerebral vascular diseases, or MIs. And so this is really important because this is a common concern of why patients are not started on stimulants with co-occurring substance use or even just ADHD. Another assumption is it could be hard to treat having other comorbidities, including with ADHD and substance use disorders. And as we see that is true, they generally do have a lot of comorbidities in the community, specifically with anxiety. And then you have to ask the question, which one should be treated first? And generally the most severe should be treated first, but that doesn't mean ADHD should not be treated along with whatever is the most impairing diagnosis. Anxiety in general is a difficult diagnosis to make with untreated ADHD, because anxiety is generally going to be pretty severe with untreated ADHD, especially in the adult population. So you should generally see the anxiety scores improve as ADHD is treated. So as I just mentioned, you want to treat the most impairing first, and this includes substance use disorder, but don't rule out treating both ADHD and substance use disorder at the same time. I just wanted to briefly mention some alternative therapies. The research really doesn't support alternative therapies over stimulants. Some can be effective, but the results are great and they aren't significant generally. The main study that had the most benefit was CBT. It was integrated CBT, otherwise just CBT wasn't significant. And potentially and this just kind of shows CBT focusing on ADHD with medication might be superior than medication, but it hasn't been reproducible across the studies. So kind of just recapping, you want to manage diversion misuse, escalating the doses of stimulants, and kind of weighing out if they're running out early. And it can be really difficult determining whether their stimulant treatment is yielding a benefit, especially when you have that co-occurring ADHD and substance use disorder. And so really want to try to find that sweet spot. If a patient has a history of substance use and they're calling to get the frequent refills, that doesn't necessarily mean they're misusing or diverting the medication. It could mean they're not on the right dose for them. So I would be kind of be cautious, but at the same time, consider actually increasing that medication and see if you can get the patient to actually last 30 days in their medication. So don't rule that out completely. And this can be the one area that really makes prescribers really uncomfortable. But as long as the documentation is there for co-occurring substance use and stimulant use, you're doing exactly what you should be doing in effectively treating these individuals. And then, of course, these are some things that you can do to decrease misuse, such as keeping track of the pills, checking state databases. These are things you all know, so I'll kind of go through this for the sake of time. Again, noticing the red flags, and it really has to do with their behaviors. How angry are they willing to come to the appointments and discuss the treatment plan and figure out why it's happening. In figuring out if they're using it to misuse or if they're actually using more of the medication to self-treat. I'll kind of go through this briefly so I have about 10 minutes left for questions. I'll kind of go through here. And so in conclusion, just to kind of recap here, remember ADHD is a neurodevelopmental disorder. It may start in childhood. They don't have to be diagnosed in childhood, but it may continue into adulthood, and most of these patients it does. With the right questions, you can always find the symptoms in childhood. You just have to kind of know what you're looking for. It remains a clinical diagnosis with evidence-based treatment that can make a substantial difference in the quality of life for these individuals. And then careful consideration regarding the stimulant use, especially in the young adult population, because that's really where you can have the most substantial impact on decreasing substance use disorder later in life. And then kind of recap some of the studies that we looked at. It's a risk factor for cigarette smoking when it's untreated in substance use disorder. It should be considered, ADHD should always be considered in adolescents and adults who are smoking cigarettes, unable to stop, and potentially have another substance use disorder. Treating ADHD helps protect against the onset of cigarette smoking, substance use disorder, and substance use disorder related criminality. The strategies exist for management of substance use and use, in ADHD. The data is there. We just have to feel comfortable to use it. And then since stimulants can be misused, consideration mitigation strategies in high-risk groups. Doesn't mean you should not treat. I recommend absolutely treating, but just have a good treatment plan in place and frequent follow-up in order to minimize risk against you and them. And I'm sorry, I kind of went through that last part. I just want to see if anybody has any questions. I don't know if anything is written in the chat.
Hello, can you hear me?
Yes.
Hi, this is Catherine Meyer. I am a dentist, and I'm wondering if you discuss the oral health side effects that ADHD medications can cause, or do you refer your patients to a dentist? We see a lot of patients who are on medications have rampant decay and periodontal disease that's exacerbated by dry mouth.
Yeah,
And so
yeah, absolutely.
We'd love to be part of the team.
Oh, absolutely. Yeah, I appreciate you bringing this up. No, I didn't really get into a lot of the side effects for the sake of time, really trying to hit on the major advances in the research, but you're absolutely spot on. Yes, major side effect is that dry mouth. And commonly telling patients at the beginning of starting the treatment, really look at, they have, which you would be able to talk about this better than I can, but the putting lozenges and having the mouthwash to increase the saliva and And if it gets severe enough, actually changing the medication. But yeah, every 6-month visits is especially important. That should always be discussed in the follow-ups to prevent the decay. So I really appreciate you bringing that up.
Stephanie, do you see that
Thank you.
question in the chat?
I'm trying to bring it up, but it's not working.
Is tachyphylaxis a problem with stimulants, and how do you best address this?
So with the newest with that study that was released in 2022, we're finding no. Tachycardia will always generally be seen initially when starting stimulants. That's going to happen, but it shouldn't be an ongoing concern. And the studies show that it's not an ongoing concern. If patients are presenting with this problem consistently on a maintenance dose, then consideration should be taken to try a different medication.
I think the question was
They were
tachyphylaxis
they were asking about tachyphylaxis if they
versus tachycardia,
yeah.
lack of long-term efficacy.
A sudden decrease in, how they have an initial decrease and then suddenly need way more right away.
Sorry, can you guys hear me? I don't know why it's not working.
Now we can.
Yes.
I apologize. Sorry, I was talking and I realized nobody was answering. I apologize. I totally thought that said tachycardia. I can just see a little portion of the chat. Okay, so yes, need to achieve higher doses? No, generally that's not the case. Once the right dose is found for especially adults and children, once you find that dose, they should never need to have it increased. There is a small percentage, and this going off the top of my head, I believe 2% of individuals may potentially need it to be increased, but it's usually due to some other reason. Perhaps they're just not responding. But after the age of 16 for adolescents, and after initially titrating and finding that right dose for adults, you should not need to increase the medications. But it's especially important to discuss euphoria and decrease in actual symptoms, improvement in their symptoms in daily life. We're not looking for euphoria, we're looking for them to function. And so that's the most important aspect.
Yeah.
So thank you guys for pointing that out.
There's another question. Is there ever a place for adding IR medication to the extended release med?
Certainly. Absolutely. But keeping the medication consistent is the most important aspect of this. So if you have, if you're using Concerta and it's not lasting long enough, then you can add a little bit of Ritalin, towards the evening time for individuals. And there's always a concern, we're going to disrupt sleep. And that's actually not the case. If you ever talk to an individual with ADHD where they are on XR, Adderall, and they get a little bit of IR medication, in the evening time, they will have the best sleep of their life. So if you are on the right dose and on the right medication, their sleep should improve even with a stimulant. So yes, there is a place, but keep it consistent across the actual stimulant you're using.
I don't see any other questions, but I do want to say, from years of observing this, if we think that treating opiate addiction is an uphill battle, boy, this is even more uphill. It is like swimming against the stream. And there's so many, there's so much evidence that people with, meth addiction benefit from this. But man, people just have a fit when you put them on a stimulant.
And the most interesting time right now is, we're dealing with the opioid use and realizing our actions. We really need to treat this opioid use, but we also have that rise in understanding ADHD. And so we're at the same time, we're realizing we need to get these individuals on stimulants. And so they're kind of co-occurring at the exact same time. And so a lot of people are fearful, which understandably so, given our past history, but treating them both is what we need to do.
Yeah, it is so heartbreaking to know how many people have probably been put into the criminal justice system because they didn't have proper treatment.
Yep,
And
absolutely.
it is so sad. And once that starts to happen, it's so hard to dig people back out of that.
What's your pearl, Stephanie? Fantastic presentation. Thank you so
Thank you.
much. Great. But that Janet brings up that question, and my thinking is, what's the pearl to most efficiently or consistently overcome that bias against treatment in people with the, how do we answer back to, whether it's insurance or referrals or whatever, how do we answer that back consistently so we can reduce that barrier to care or the tendency towards under treatment?
Yeah, certainly.
Approach that.
And it all comes, and let the data speak for itself. I mean, like I said, we do not have any other medication that so successfully treats a diagnosis as we do with ADHD. It's shocking. Even with cardiovascular disease, GI, any other medical diagnosis, it's such a substantial increase in response. We don't have any other medication that treats something as well as we do with ADHD. And so really, I mean, giving them that study, I mean, they can't argue with the research because they're going based off, the guidelines are based off that. And this is what it says. It says you should go above. The max dose is arbitrary. There's no studies that actually have found to be the right dose for the maximum dose. And the FDA just chose it because that's all that was studied. But the newer data shows we should be going higher for individuals with substance use disorder. So that would be my argument.
I like that answer. And also I took it because it was so symmetric with opioids in terms of objective observation and communication of function.
Mm-hmm.
Measuring function in a meaningful way and demonstrating improvement in function should be a winning argument as well.
Yep, absolutely. And a lot of times these patients don't know that they have it, and they will, almost be resistant to the diagnosis because this is all they've known. It's like, what are you talking about? I've always just been this way. I'm always late. I've always lose my keys. This is just who I am. I've lost so many jobs. It's never going to change. It will change. It absolutely will change. They just, haven't found it, haven't been on the right medication for it. And that's unfortunate.
Mm-hmm.
Great presentation. Thank you.
Thank you very much.
And thank you guys for reading the chat to me. I don't know why I can't pull it up.
Well, probably because your slides are there.
Yeah, probably.
Yep. Thanks, Stephanie. Great job. Everyone, participants on this training, there's a link to the evaluation survey in the chat to get your certificate. Keep an eye out. An email will be coming out to you in about an hour or so. Oh, I did see a question. A list of references or resources. Stephanie, do you have something you could send me?
All of my references are actually listed in each slide where with the specific study that was done. So
yeah, I think you froze up, but I'll get the slides from her and send that out with my email this morning. So yeah, have a good day, everyone. Thank you.